Okay, so let's talk about gut health, because I know that's something that you've been interested in and you have some opinions on, and I'm sure that's something you look at as well in your practice. So I guess one question would be, how do you approach that? What are the things that you will ask, measure, and what don't you
Yeah.
look at?
So I see two groups of people. I see healthy people that want to stay healthy. Maybe they need to lose weight, but basically fall into this concierge preventative medicine bucket. And then I see another group of people with chronic GI issues. So I see a lot of people that have chronic constipation, irritable bowel syndrome, and that's because of why I got into medicine. I had chronic GI issues growing up. So literally the only reason I went to school was I was like, I got to fix my gut. Like I can't live like this. And I learned a lot about it. And it's also why I am so harsh on what is snake oil and what's real, because I've tried everything myself and feel like a little burned by people where I'm like, how did you suggest this to me now that I know this on the other
Yeah,
side as being a
right.
clinician? So I want to protect people in that manner as well. But in terms of like the healthy people that come in, they just want to live longer, they want to stay healthy. I'm asking them baseline questions. How many bowel movements are you having per day or per week? Excess bloating, gas, flatulence. It's normal to fart up to 20 times per day.
Apparently, you can be genetically predisposed to this.
And we don't know. So, yeah, exactly. Normalizing like normal bowel behaviors, making sure there's no blood in the stool, like red flags, reflux, things like that. That's all I'm doing with these preventative medicine people. So I'm not doing microbiome testing. And we should dive
Yep,
into why I don't do
we'll do that
that.
next. Yeah.
And if you come in with GI issues, then we're going to work that up if it hasn't been worked up. So if you already have a diagnosis of IBS, then we're just going to go ahead and start treating you. If you don't have a diagnosis or the diagnosis seems questionable, then we're going to do a full workup, which could include a stool test, but it's not going to be your direct to consumer testing. So I'm sending you to LabCorp to Quest, and we're just ruling out specific things that could be the cause to your symptoms.
Do you use Cologuard? What do you think about Cologuard, since we mentioned colonoscopy previously?
Yeah, Cologuard's a really useful tool. It does not take the place of a colonoscopy.
Sure.
So if you are due for a colonoscopy, it doesn't matter. I'm really pushing you to get that colonoscopy.
Yeah.
There's some people that just won't get a colonoscopy. Then the best next thing would be to do a Cologuard versus nothing.
Or potentially in between, I'm guessing, especially if you're like 10
Right.
years apart,
Yeah,
right?
to use it as a filler
Yeah.
to get just more data.
Yeah.
There's yeah, absolutely.
But like in my case, I had 3 polyps. Cologuard's not going to help there. You actually
Cologuard's
have to get the
not going to
procedure
help.
and get it removed. Yeah.
Won't detect the polyp and
Yeah.
won't colonoscopy. We forget it's a screening tool for colorectal cancer, but it's an intervention
Right.
as well.
Exactly.
You're removing that polyp when you're in there for the colonoscopy. Right.
Okay. So you mentioned microbiome testing. What do you think about that topic?
Yeah, I'm trying to think of what you got so worked up about. Like this is the equivalent for me.
Okay.
Oh, it's the age test.
The biological age test. Yeah. And I think there are some parallels there, which we can talk about.
Yeah.
But so maybe first describe, what do we even mean when we say microbiome testing? Why would we want to do that?
Yep.
So I think it's important for people to understand, there's the direct to consumer tests and then there's the science, and those aren't always going to be exactly the same.
Yes. So you've got people like Rob Knight, who I think is in San Diego at this point, who's one of the lead researchers on microbiome sciences and like how our gut microbiome affects different parts of our body. And he is obviously sequencing the microbiome when he's doing his studies. Love it. We need more of that. Like, let the PhD researchers do all the things that they need to do to find the answers that we need. So I'm not talking about that. There's a huge utility, and exponentially more papers are coming out about the gut microbiome. So when I say this, I'm never playing down the importance of the gut microbiome in our health. What I'm saying is that if you are at your house and you're scrolling through Instagram and you come across an ad that says, mail in your poop to this X, Y, and Z company because it's going to tell you how to lose weight and, they've claimed so many things. What diet you should be eating.
Yeah, that's a big one I've seen, yeah.
What food sensitivities you have, just put anything in that place. Run. Turn around and run. Get off your phone. Like, do not purchase. Because most of those are not using practices that are going to be helpful. But the biggest thing here, and I've talked to Dr. Knight about this, we currently do not know enough about the gut microbiome to make clinical decisions based on the results that we get. we don't know what the ideal gut microbiome is at this point.
Mm-hmm.
I like the analogy of like, Matt, you have a fingerprint, I have a fingerprint. Mine's not bad, yours isn't good. They're different. Now, do we think that there's certain gastro diseases that could be in part due to the gut microbiome? Yeah, we do. But even with those, we still don't know what the answer is most of the time. Couple distinctions where you have like Clostridium difficile infections, right?
Right.
Which causes a pseudomembranous colitis, can be life-threatening, especially in the elderly. And the first FMT product was approved just it was either 2022 or 2023, Rebiota, which now we are using for treatment-resistant recurrent C. diff infections. FMT is when you take the stool of a healthy donor, infuse it into a diseased person.
Right. Fecal microbiome transplant.
But we still don't know exactly the people that, like the microorganisms that need to be there to help that person.
We don't have enough precision yet to be able to map it that well.
Yeah.
So let me just ask a very simple question so that people can understand. Is there any FDA approved microbiome test that people can buy right now for a condition that would be relevant for them that you're aware of?
For a condition that would be relevant.
That they can go online and buy without a doctor's prescription.
I'm like, we're not talking Cologuard. You're talking about the microbiome.
Right. Microbiome test.
Microbiome test. No, there's nothing that I would recommend that is direct to consumer at this point that would have a utility for the general public. And one other thing I like to tell people, which makes it more tangible, is that, first of all, what comes out of you that you would collect as a stool sample is exposed to air. A lot of the bacteria that are in our intestines are anaerobic.
Right.
So we're not getting those guys when we're sampling. So there's sampling issues. And then there's the issue of like, you do like GI map, like some of these big companies that are doing these tests, even if a doctor is ordering it for you, so not even direct to consumer, but requires a doctor's order, they're going to give you a list of maybe like 20 microbes, maybe more, maybe like 50.
Yeah.
It's cherry-picked examples of the entire microbiome.
And also very sort of high level groupings, right? I mean, again,
You're
it's
looking
a whole,
at the genus level.
right? There's probably thousands of species in there, and we don't even know at the genus level what that signature means, let alone which of the species within that are relevant for the 100%. Conditions.
So like the genus level, if you're listening, is for E. coli, it's Escherichiae is the genus level, the E part of it.
Right.
And so Escherichiae has many different species, and then within each of those species, many different strains. Right. So you have E. coli 0157H7, which causes diarrhea, traveler's diarrhea. And then you have E. coli Nissl 1917, which is a probiotic that is helpful for people with constipation and sometimes ulcerative colitis. Those are in the same genus and very different strains. And you have examples all across different genus levels.
Right. So again, just kind of take it high level first. So in your opinion, these tests don't give you any actionable information for your clients. Is that
yeah, it
a fair
doesn't
thing
mean
to say?
Like if somebody comes to me and they have one of these, I will scan it and I'll look at, okay, was your calprotectin high? But if I'm going to run it, I'm going to send you to Quest. Insurance will fully cover a calprotectin level. It does not need to go through an expensive cash pay company.
And that's a specific thing you'll look at, not, in this panel of lots of different.
Exactly. And I also question the accuracy of a lot of these companies too. I'd much rather send you to a company who's running I don't even know how many samples of this per day and has been tested.
And do we have any information on precision, I guess, because accuracy is hard. I guess we could tell both precision and accuracy. So precision, of course, is how close are the repeated measurements themselves. Accuracy is how close are you to the true value.
True.
Right. But I mean, do we have any information on these direct to consumer companies on, if we could talk about my biological age test experiment, but the correlate would be you get, 8 different microbiome tests, you use the same sample, you send it in under different names and see how close do they match each other.
Yeah, I'd love to do it. And maybe I'll add it to my list. But what I know just from experience, because I've had hundreds, people come in all the time with these. So I've seen thousands of these tests, and the number of people, I won't name the actual lab company, that come back positive for H. pylori, it's crazy. I mean, it's like so many people, and I'm like, wow, is this that? So and are they just more sensitive than Quest or LabCorp, I'm not sure. But what I know is I send them to Quest or LabCorp and they get a negative result every time.
Right.
So like I've maybe had one true positive in that
Interesting.
case.
Yeah.
So, and you don't want to give somebody triple antibiotics based on a lab test that.
Right. Absolutely. Right. Which could do more harm for sure. Yeah. I mean, I think this is one of the challenges with the direct to consumer space in the sort of diagnostic or testing area where, I mean, I'm sure many of these companies are doing things well, they're using, good clinical practice or good laboratory practice, but I don't think there's any requirement that they do. And these things are not, in theory, they're regulated by the FDA, but the FDA doesn't seem to be paying any attention. As far as I know, none of them are approved by the FDA to measure anything. So I don't think consumers really understand. It's really the Wild West in these direct-to-consumer companies. And as far as I know, like you and I could decide today, we're going to put up a website and claim we can measure whatever we want to claim we're measuring and sell a test for it.
Terrifying.
Yeah. So, and I mean, I see a lot of parallels as we've sort of talked about between the microbiome testing and the biological age testing. The only thing that might make me a little bit more optimistic about the microbiome testing is that, at least in theory, if we could get the precision down and understand, I think part of my challenge there is we don't really understand, I don't think, which microbes are, good or bad. That's probably another thing that drives you nuts, right? This idea that there's a good microbiome and a bad microbiome. But we can understand which bacterial species in what proportion drive different biological outcomes. Then it's pretty logical to me that you could intervene, right? In theory, with probiotics or prebiotics. I want to talk about that. Whereas with the biological age test, to me, at least the current crop, even if they were measuring what the companies claim they're measuring, and I don't think they are, it's not clear to me what you do with it.
What you do with it. Yeah. Interesting. Yeah. Yeah. And that's where I tell people, it's like, I haven't thrown out the idea that microbiome testing is not going to be a thing at all, ever.
Yeah.
It's just, we're not there yet.
Yeah.
So like, let's wait till we have a good product.
And clearly super important. Like the microbiome itself is clearly really important for a bunch of different health outcomes. And probably worth saying, most people talk about the gut microbiome. We have an oral microbiome, we have a skin microbiome, we have other microbial communities in our body. We just think a lot about the gut microbiome, but it's not the only important microbiome. But yeah, if we could understand it and its impact on all sorts of different biological processes, for sure, it's going to be important.
Yeah. And I think an area that's going to be almost even more interesting potentially in this area is the byproducts of the microbes.
Yeah.
So you have these metabolites, like our microbes, I almost think of as a city, and some of the factories in there are producing, this food versus other factories are taking up that gas and producing something else. And you're looking at the function of these microbes. Because if I told you we have a city and we have 5 doctors and 3 nurses, and then we have another city and we have, 20 healthcare professionals, but you don't know who they are. Like, we want to know what these people are actually doing in there. What are they producing? What are they utilizing? So the metabolites piece, I think, is almost more interesting because I can see us being able to measure levels of metabolites and have more objective outcomes in terms of, wow, we need more of this and less of this.
Yeah. And there's certainly on the basic research side, a growing body of research looking at bacterial produced metabolites and how they can get taken up into the body and impact different cells and organs. So yeah, it's going to be really important. What are your sort of general thoughts on probiotics?
Probiotics are a useful tool sometimes, but I think of a probiotic just like I think of an antibiotic. So I would never give somebody a random antibiotic to treat whatever, right? So if you come to me and you have a UTI and you're a woman, I'm going to use macrobid. Like that's just what we do, right? And so same with probiotics. You don't want to throw a random bacteria in there just haphazardly. They're like a key in a lock. So we know that the research says that some strains can produce some outcomes in some people. And so if you come to me and you have ulcerative colitis, I'm going to give you the strain that's been researched for ulcerative colitis. I'm not going to just put you on a broad spectrum probiotic. For the person that is healthy, no complaints, I don't recommend a probiotic. I don't think there's enough research to support just a daily probiotic.
Got it. Yeah. I'm really glad you said that because I don't know that I've actually heard very many people frame it that way, but I also share the concern that, probiotics are not that different from drugs, right? In the sense that you're giving something exogenous to modify a biological system. And, I think probably most probiotics are harmless because they probably aren't doing anything, but you could change your microbiome in a way that's not great and have a long-term consequence. And again, it surprises me that FDA doesn't actually seem to regulate that at all.
Yeah.
Like you can just give all sorts of bacterial species.
The whole industry is like that, but people are often surprised. I use them sparingly. Like if I have a bunch of people with chronic GI issues, they're not all on probiotics. Like the research behind them isn't that great for most conditions.
So what do you do for chronic GI conditions? I mean, obviously it's going to be, you're going to do a bunch of testing and try to put people in different groups, but I mean, what's your sort of general strategy?
It depends on what the condition is, right? So if somebody comes in with IBS, which is 10 to 20% of the population has IBS, it's a huge subset of people. But if somebody comes in with that, I'm going to first identify which group they fall into. So they have diarrhea, they have constipation, or they mixed. And then we'll go down this kind of level in terms of first diet, exercise, lifestyle. So are you doing everything in that bracket? And there's a ton there.
Just so that I'm clear, IBS is just a symptomatic diagnosis, right?
It is based on just symptoms. There's no biochemical marker for IBS. Yeah, so you're basing it on symptoms, but it's not a diagnosis of exclusion. So it's not like, oh, you don't have any of these other things, so you have IBS.
Right. Yeah.
So you have to have certain criteria.
What are the criteria?
It's abdominal pain has to be present in IBS. So that's a big one. And then it's either going to be somebody that has looser stools or more frequent stools for IBSD, or hard stools, more infrequent stools for IBSC. But it's a change in bowel frequency, bowel habits, consistency. But the abdominal pain is a keynote there. Most people with IBS will also have bloating and excess gas. But
is it age related?
It's not age related.
Oh, interesting.
It's gender related. So it's 2 times more common in women than it is in men. And what's really interesting in my mind is that changes and becomes, so when women go through menopause, the rates between men and women go away.
Oh, interesting.
So it may be hormonally related as well. But the big thing with IBS is there's a diet component. So a low FODMAP diet is going to be helpful in a group of people, but not everybody. And that's where we have a ton of a focus on the gut-brain interaction. And this is like a phrase that's thrown around in so many different camps, but your gut and your brain talk intimately to each other. And in IBS, it's almost like there's a kink in communication between the two. And the signals in the gut are getting sent to the brain and distorted. So we're getting a different signal that's happening in the brain. It's almost like there's a fire alarm going off in the brain, but there's no fire that's there. And so we have pain receptors in our gut, and these pain receptors can be hypersensitive to distension or gas. And that's one of the things that we think is going on in IBS. You have something called visceral hypersensitivity, where if I put this much gas into your intestines, you might not say anything. And in somebody with IBS, they would say, ow, that doesn't feel good. And it's not that they're being a baby or whatever. There's an actual receptor that's going off that's misfiring. And so there's cognitive behavioral therapy techniques to help restore that normal communication between the two. They're evidence-based. They have great research. If you look at the American Gastro Guidelines and how to treat IBS, it's in there. It's just that most GIs don't have the time to actually implement this because there's a huge education component, and we have a huge shortage of psychologists who understand this gut physiology component as well.
It sounds like it's a really prevalent issue. I mean, you said 10 to 20%. That's crazy.
So prevalent and so misunderstood. The amount of people that will come into me and they have IBS and they're like, well, I took out gluten and dairy and soy. And I'm like, you didn't have to. Let's put those back in. There's a few dietary things that may make a difference, but we really need to restore this communication between the gut and the brain. And then there's pharmacology. There's things that speed up the gut, things that slow down the gut, depending on which one you go through. And there's definitely supplements. So like psyllium husk is one of my favorite supplements for IBS. Acts as, obviously a fiber source. So it can help with diversity in the gut microbiome, helps to kind of fluff up the stools.
Is that the scientific term?
Yeah, it's very scientific. For normal bowel movements, reduces the risk for colorectal cancer and basically many cancers.
Yeah, we talked about probiotics. We didn't talk about prebiotics. And so psyllium husk for IBS. What about for everybody?
Everybody. It's one of my favorite supplements. I mean, I just have a hard time getting people to actually take it because it's, have you ever taken it?
Mm-hmm.
You don't mind it?
No.
It's
Some people, you mean the texture?
Yeah, the whole experience of it. So you're putting a fiber into some sort of fluid. You need it
yogurt.
To be with I do yogurt sometimes, but even with yogurt, you want to make sure you have 8 ounces of fluid next to it because the fiber is going to kind of soak up a lot of that liquid and you want to make sure you have a hydrated intestinal tract for that. But yeah, it's just it's not the best flavor and you have to drink it. I think pills are usually easier for people, but love it.
And do you recommend anything else with prebiotics?
Psyllium husk is really my go-to, but then you just have foods that are high in prebiotics, like your onion, garlic, leeks, artichokes, and those have tons of health benefits too.
Right. Yeah. What do you think about leaky gut? And people talk about this in the context of aging, like a breakdown of the gut barrier. Is that something, tell me what you think.
I think that we still need to research it a lot. So, and there's eclectic lab companies that will test for leaky gut too. A lot of those comprehensive stool analysis will do a zonulin measurement in the gut and make decisions based on that. And I just don't think we know enough about how should we be testing it, what markers should we be using, and what's the cutoff. From me reading the literature, ulcerative colitis and inflammatory bowel disease, it looks like there's going to be an involvement with intestinal permeability there, which is kind of obvious because you have ulcers in the intestine. Right. So it's not an aha moment.
Yeah.
Maybe IBS at a much lower degree as well. But I'm not for doing these tests and making clinical decisions just because I don't think there's enough there yet to warrant it at this point.
Yeah. I would say in the aging field, it's not particularly well studied, but I've seen what I consider pretty compelling evidence in both mice and primates that this happens with aging, meaning that there is a decline in function of the gut barrier. Now, to what extent, again, is that a cause of inflammation? Probably plays a role. But I think what you're saying is, well, even if that's true, we don't have great ways to measure it. And so it's not something that's super actionable from a clinical perspective yet.
Yeah. Yeah. And it makes sense that it's going to happen as we age. So not denying that, but I think that we need a little bit more in terms of we have a test where you drink sugar and it's a combination of 2 sugars. One of them should not be absorbed by the intestinal tract, and then one of them is fully absorbed. Right. And you can measure urinary metabolites of that to see what's
how much is
through.
Passing across the barrier, and if you're getting more across than you would.
Yeah, so that maybe, but again, what is the cutoff, and what does that cutoff mean? I think we need to get more granular with.
And I'm guessing, this is not my area of expertise, I'm guessing we just don't have enough data across a normal population to really know what the reference range is. Look, I'm sure they have reference ranges, but I don't know how widely that's been studied.
Yeah. And that's the issue with most of these tests is who are we comparing this to and what do we actually know is the ideal and what's not.
So I think I know what your response will be, but I don't actually, people don't really believe this, but I listen to very few podcasts. I'm not somebody who consumes a lot of podcasts, but I was listening to a podcast recently and there was a doctor who's a concierge doctor talking about how you should take microbiome tests. I already know how you feel about that. And then based on that, modify your diet to prevent leaky gut because leaky gut leads to leaky brain.
That's the soundbite for that one.
So that's just an example, I think, of the kind of questionable information that you can find out there.
I get it. I understand where you're going, where that person is going with it, but no, I would say just no. And there's so many. We could do a whole podcast on this one thing, but yeah.
So we've talked about microbiome tests. This is kind of again, take a little bit of a higher level approach. Where do you land on different diet types and what have you seen that you think is good, bad, ugly? And you can answer this in any kind of way you want to, but most people are going to think keto diet, carnivore diet, plant-based diet. how do you think about that? Is there a best diet in your opinion?
Yeah, this is something that if you asked me when I was 22, my answer would be very different than what it is now in terms of like, there's no dogmas anymore. And I don't think that there is the perfect diet for every single human. I think that you have to individualize just in terms of like, what will people actually eat? What are they more apt to do? Do they need to lose weight? And which lever are they actually going to pull to lose that weight?
Right.
And if I've worked with like so many people on weight loss at this point, you know that everybody's different. There's going to be people that they're like, I just need a window of time to eat in. Like, that's how I lose weight. Great. Like, we can do the time restricted feeding for that person. And then there's people that are like, I want to be able to eat whenever, and I'm just going to reduce total calories. Great. That works for that person. So I think that you just have to be able to be flexible depending on who the person is that you're working with. In terms of like carnivore, keto, vegan, vegetarian, I think that a lot of these are hyped, and I think that marketing has gotten a hold of some people, and some of them sound sexier because they sound like this quick fix, and they're so different than what, we've said in health all this time. So I think people just like different a lot of the times. But I'm really hoping, like, I go in terms of hierarchy, like calories, like, okay, we need to make sure that you're having a good amount of calories for you, whether you're trying to gain weight or lose weight.
Yeah.
And then after calories, it's protein, making sure you're getting enough protein to build muscle mass or, wherever you.
And I know there's not one answer, but what's enough protein for you? Guidelines. Like
generally a gram of protein per pound of ideal body weight. Really rough.
But that would be considered high in many circles. Yeah.
Yeah. It's definitely on the higher side.
Okay.
And then after protein, I go to fiber. So are you getting your recommended fiber amount? And 5% of Americans are getting the recommended amount of fiber.
What is the recommended amount, and what do you think is optimal?
Depends on the agency, but it's anywhere from 14 grams per 1,000 calories consumed, which I like because it takes into consideration how much food you're eating.
Yep.
Or another guideline would be 25 grams of fiber for women, 38 for men.
In a day.
Yeah. And that's kind of where I aim for people. And I do food logs. So I have them do logs of food for X amount of days. And we go see how much did you actually eat. And a lot of people are very surprised that they're not meeting the fiber. And if you meet your fiber requirements, you're also going to be eating more fruits and vegetables, which we know reduces the risk for basically everything that's there. And that's where like the carnivore thing, you're just negating the evidence that we have about fruits and vegetables and fiber and polyphenols and all of this stuff. And I don't get it.
Yeah.
What do you think about it?
No, I was, as you were giving that answer, I'm like, wow, we think a lot alike when it comes to food. So, I mean, I approach it sort of the same way. I mean, I think, I'm pretty high protein, probably close to what you were recommending. And then, beyond that, focus on getting enough fiber. I guess at one place I'd be interested to, because I think I heard you on a different podcast talking about sugar, and you made a comment about how sugar's not you can tell me what your words were, but it's something like sugar's not bad, or sugar's not a bad guy, or people hear sugar's bad. And okay, good. We should dive into that. But I try to minimize added sugars, I guess I would say, in my diet. Yeah. But let's jump into that. So why
you can agree with both of them.
I agree. They're not mutually exclusive. Yeah. But I mean, I think there's some nuance here, right? Yeah. And so I'd like to hear your nuance, and then we can talk about like, what is the right message for most people to get?
Yes. Yeah. That's a good point. We also have to realize that, 60-something% of the population is overweight or obese, right? So if we're talking to the masses, then we should be talking in those categories. But then there's people that aren't overweight or obese. And we have to be talking to them too, because especially when we're on podcasts, we make these blanket statements, which people do. They'll get on and be like, sugar is the devil. We need to get rid of all sugar. Sugar is killing you. It's causing cancer. It's causing every disease. And I'm like, that's just not true. Yeah. Like, sugar is a molecule. We know the chemical structure of it. And that structure is found in fruits, vegetables, and Snickers bars. Right? Or there's a starch that breaks down to the sugar molecule. Right. But I think if we demonize that molecule, then we just don't understand physiology, because that molecule is circulating in our blood. It is the source of fuel for our brains and all of our organs. And to say that it's bad just makes no sense to me. And so I think I also think when you demonize something, you're creating polarity, and from a marketing perspective, people love polarity, but from an actual like scientific research base, like we shouldn't be just putting things in a category to make them sexier. That doesn't make
Right.
any sense to me.
Right.
And so I think sugar is sugar is sugar. And should we be eating tons of it? No, especially if you're overweight or obese. But let me give you the example of, I just had Sebastian Zorn on my podcast, who's the dietitian at the LA Rams. And if you look at a guy who's 220 pounds and he's 18% body fat and he's going to go play in the Super Bowl, is he going to be eating simple sugars to improve performance? 1,000%. Gels, juices,
Right.
right? And like that would be an ideal thing for him to do because that's his goal. You take a 220-pound male who is 38% body fat and isn't going to go to the kitchen tomorrow, yet alone do a Super Bowl. Like, is that ideal for him? Definitely not. So this is where individualized medicine comes into play, but it's so obvious when you have these opposite sides of the spectrum and people forget the nuance all the way in between because those nuances exist even here where it's like me personally trying to put on 10 pounds of muscle over the next few years. I have simple sugars in my diet all the time, but I also have fiber and I have enough protein. I have all these other things too.
Right. Yeah. I mean, I think that's really important. And like you said, it really depends on the individual's lifestyle outside of just food and their situation. And 60% of Americans are obese. And so I think I want to talk about that a little bit because I think, one of the things that, I mean, it's kind of obvious, but is important to say. And if you actually read labels, like almost everything in the grocery store that's not around the edges has added sugars.
Mhm.
And I think that's driving to a large extent the obesity epidemic that we're experiencing. So how do we communicate to people the importance of actually paying attention to what they're eating without the sort of, sugar's bad, don't eat any sugar?
Yeah, I think education. I think we need to educate. I think that should be like our number one priority is talking about what's the difference between added sugar versus sugar naturally occurring in
Right.
an apple.
Right.
And so I think we just need to, we really need to educate those people because the apple is great for you,
Yeah,
right?
I'm laughing. I'll be interested to get your thoughts on this because I joke about it now, but I got a lot of heat because I said half joke, mostly joking. I said bananas are a Snickers bar masquerading as fruit.
Yeah, I get it, but like I think a banana could be a really healthy part of a diet, especially it totally depends on your goals.
Sure.
It could also be something that's like, wow, why did you have 3 bananas in that shake? You need to lose, 20 pounds
Yeah.
and like it's not appropriate.
I think the
but-
point I was making, I mean, and you know this, right? There are a lot of people who are pre-diabetic or diabetic, right? Banana may not be the best choice in terms of fruit for that person. But anyways, I just thought it was funny because lots of people got all upset about that. The banana mafia came after me. did not like that.
Yeah, but it just meant how much movement are you doing through a day? How much are you going to burn? And that's where we get more nitty gritty.
Yeah. So, okay. So not a big fan of diet, like hardcore diet fads, it sounds like though. And you must have patients who like swear by a keto diet.
Mm-hmm.
Do you have any who are like hardcore carnivore?
I've had, so definitely I've had a few.
And do you see anything there that is concerning or can that work, do you think, for a fair number of, aside from the fact that, it's going to be hard to get the fiber that you think is optimal?
Yeah, I think the fiber is an issue. And so how would I approach that person and how I did approach them is number one, why are you doing it? So like, what are your thoughts and beliefs? Like, do we want to dismantle some of those? Like, are those thoughts and beliefs actually serving you? Because if it's just because Carnivore King on Instagram said to be that way, like maybe we should reevaluate. But if it's because you feel so much better and everything's good in your life and you used to have all these issues, then okay, let's actually have the conversation. But we want to run, especially on them, ApoB, LP(a). We want to see, are their cardiac markers in line or do we have to? And in some cases, someone's like, I have this patient actually who's like, I really want to use coconut oil and these other saturated fats. It's like, okay, like I don't have enough evidence necessarily to say that that's going to crush your health because everything else is in line. And we can use a statin to get your ApoB down because it's getting affected by that. But let's just have the conversation. There's obviously some data with saturated fat, but if we can make sure you're not insulin resistant, you don't have any other, risk factors, then I'll work with you, basically.
So do you have any sort of general, like what would be your general dietary tips for people?
Start with calories. How many calories should you be consuming? Make sure your body composition is at an
Calories,
optimal range.
protein, fiber.
Yep. Calories, protein,
What about
fiber.
processed foods?
I like to talk about the hyperpalatability of food a little bit more. So ultra processed foods, I think we reduce them, we get better outcomes in general. But there's exceptions. There's like whey protein, right? That's an ultra processed food.
Mm-hmm.
And I think can be a really healthy addition to any diet. So the hyperpalatability of food, I think, is more of a way to put things in camps a little bit easier. So if something's hyperpalatable, it means you can overconsume it at a much easier rate. And it usually has a combination of ingredients, either like sugar and fat and salt, like something that's making it very easy to overconsume. And I for sure think majority of people should reduce their intake of hyperpalatable foods, unless you're underweight. Then
maybe that's the best thing for you. Yeah, interesting. It's funny because when I was talking with Peter recently, and this is on the podcast, so I'm not giving away some deep, dark secret that he has. I think he said that he has protein bars and venison sticks for breakfast every morning.
Mm-hmm.
And I'm like, hey, if that works for you.
And technically ultra processed, right?
Right, exactly.
Yeah.
Yeah, and I'm not suggesting that's a healthy option for most people, but seems to work for him.
It's an example of where processed foods can make things so much simpler, and they're not always needing to be demonized either.
Right.
Yeah.
Right. Okay, so what about supplements? Where do you stand on supplements, and are there any that you commonly recommend or?
Actually, I have a whole course called The Truth About Supplements.
Okay.
It sounds daunting.
Let's dive into it with the time we have remaining, because supplements are really important. Again, a lot of confusion out there. So I'm interested to hear your thoughts.
It's an unregulated market. You don't know what's actually in the supplement. So choosing something that has some sort of certification, whether, like the most simple ones, GMP, USP, and then getting up to a better marking in terms of certification, you're looking at NSF Sport. So those are things that I
that should be on the label.
Yeah, it'll be a stamp on the label.
Are we sure that they're telling the truth when they put it on the label?
If they have NSF or NSF Sport, they're telling the truth or they're breaking the law. So, but I mean, technically I could produce something in my house and put it out and just like.
I don't know enough about the industry other than you hear horror stories.
I know. No, it's true. So that's one thing to look at. And then 99% of supplements are BS, flat out. And then you have things like psyllium husk, which we have tons of.
And just to be clear, by BS, you mean not so much that they aren't what they're labeled as, although that can happen, but that there's just not a lot of evidence that they work as being claimed.
Exactly. Like on my past podcast, talked about resveratrol, right? Has been claimed as an anti-aging one. Doesn't have research to back it.
Right.
And then one key to look for is in social media when you're like, wow, everybody's talking about colostrum now. It's likely because that company has initiated guerrilla marketing for their product.
Right. Marketing
and
is huge. Absolutely.
Everybody to spread the word.
Right.
And so that should be a red flag as to, okay, these are just dollars. It doesn't mean there's actual science behind them.
Right.
And so, we have AI now where you can start to do meta-analysis on your own. You need to know the prompts and things, but we can learn so much. And majority of supplements just don't have enough research that's in humans and validated and repeated to warrant taking them. But I think things like vitamin D, if you have suboptimal levels.
We can measure it, right?
We can measure it.
Yeah.
Fish oil, I think, has enough research to, especially for certain populations. That's one that I'd put in there. Psyllium, fiber sources, whey protein, creatine, I'd put in the category of has enough research for sure.
Yep.
And there's a few other ones like magnesium, especially for constipation, works really well for people. It's osmotic laxative.
Right.
But be careful.
Yeah. Multivitamins.
No research. Do you know of research?
Well, there's research. I mean,
no
no evidence for strong benefit. Or benefits.
Yeah, unless you're in the population of for some reason you're not absorbing things or you're susceptible to deficiencies. So like in the elderly, we can see some benefit with some people. Definitely a prenatal if you're trying to get pregnant, especially for the folic acid with birth defects. So, and like ulcerative colitis when they're not absorbing things, especially in a flare,
Yeah.
a multivitamin or even IV iron is needed in some cases. But in general, healthy person, multivitamin, waste of money.
Yeah. Yeah. I think I agree with that. And yet I've started taking a multivitamin
Why?
honestly, it's just like, an insurance policy. Like
Yeah.
I think the likelihood that it's going to be harmful is close to zero.
Mhm.
The likelihood that there's going to be any real benefit is also close to zero, but it's also not super expensive compared to a lot of the supplements that people waste money on. I just feel like, there's not a lot of downside.
Make sure there's at least like an NSF.
Yeah. 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 But I totally align with you on the other stuff. I mean, I think again, it varies a little bit, but right now I take the multivitamin most of the time, omega-3, vitamin D.
Mm-hmm. What about NAD and NMN? Are you taking any of those?
I do not. No. And the research, I mean, again, I would put in the intriguing bucket from a research perspective. I don't want to talk for too long because I've talked about this before, but a couple things to appreciate. For longevity data, none of that's really been reproducible. So it's probably not a pure longevity treatment. Mm-hmm. And nicotinamide or niacin will boost NAD levels as much as nicotinamide riboside or NMN for, fraction of the cost. So there's a lot of dishonest marketing around the NAD precursors in that way as well. And there was one preprint, hasn't been peer reviewed yet, I don't think, one study with NMN in mice suggesting that it may cause kidney pathology in aged animals. As far as I know, nobody's looked in humans or companion animals. So, I'm sure you know this, but I think a lot of people watching may not. A lot of these supplements can be sold over the counter because they're quote unquote generally recognized as safe or GRAS, but that just means they haven't been found to be dangerous yet. Yeah. And there have been many things that have been pulled from that categorization that turned out to be dangerous. And so people think that they can take these things safely, but it's not always the case.
Yeah. And in terms of something like niacin, so we used to before my clinical years, but niacin used to be used to help lower Lp(a), but there was no clinical benefit. So even if you saw a reduction in Lp(a), it didn't lead to reduced incidence of major cardiac events.
Interesting.
And so I don't know if you've seen anything similar.
No, I wasn't aware of that. I'll have to look into that. That's really interesting. I didn't.
Yeah,
like
you're getting the biochemical change that you would think would benefit somebody, but it's actually not translating to improved clinical outcomes, which is what we care about. We don't care that you have low Lp(a). We care that you don't have a heart event.
Right. Well, it sounds like we align pretty closely on supplements as well.
Yeah. Check.
So, yeah. First of all, do you consider yourself a concierge doctor? And what does that mean to you? And then how does that differ from primary care? Because I think a lot of people still are in the primary care world and they don't even know what that means. So what does that look like to you and in your practice?
That's a great question. I've actually never answered this on a podcast. It'll make me think about it too. I do consider myself a concierge doctor with a focus on preventative medicine. And it's different. Well, my scope is primary care. I'll say that. So Kevin, I think, is ER doc trained, right?
Right.
And so my scope is primary care. I don't fully practice primary care at this point. So if you want a pap smear, it's not me. I'm not going to do that in my practice. There's a couple things that I don't do, and I just have them do it with their actual primary care. But for the most part, we're going way deeper than primary care. So I work with people over a long period of time. Most of my patients have been with me for years. Most of the time I've seen most of the members of their family, and we work in a really in-depth setting. And what that looks like is we go through, I have this list, which I know you guys do at Optispan too. And I'm kind of checking off these things that we want to get through in terms of reducing your risk for chronic disease. So we're not just waiting till you get something and then figuring out how to treat it. I'm saying, okay, based on your family history, based on your exercise, lifestyle, behaviors, what are the most likely things for you to get? How do we screen for those if we can? And how do we reduce your risk? And obviously we don't have the answers to all of this, but we have some of them and we can utilize them. And that's how I work in my practice. I don't take insurance. So that's like another difference is this is out-of-pocket care. And because of that, I now implement a few different ways where I can put charity into it. So I tried to almost even the playing field in terms of I work with some people who are financially at one place, and then I'm trying to help other people in other ways as well.
Yeah, I think that latter piece is very important. I think there's this perception that concierge medicine is only for rich people, and I mean, I understand why people have that perception. Maybe it's worth just saying. I think there are concierge doctors that charge a variety of different levels, and some maybe it's $100,000 a year,
Yep.
some maybe it's $1,000 a month,
Right.
and all in between.
Totally.
So this I'm interested in one of the things you said about primary care, because even I'm still a little bit confused. Like, what is primary care, and where's that line between primary care and concierge care? And I get the insurance part. So that's one thing that's often different. Many concierge docs won't bill insurance. It's all out of pocket. Although I think, correct me if I'm wrong, people can submit to their own insurance company. But so how do you think about that? Or maybe it's not black and white. You can just tell me that's a dumb question. There's no black and white.
It's not a dumb question. It's not a super easy one to answer, but I basically lead people through it. So I don't make them figure it out. I'm kind of going to give them the roadmap.
You tell them what you do and what you don't do. Yeah.
But like, for instance, I have people that live in San Francisco who I may never see in person. I have, people that will fly in to see me once a year, in which case I can do a physical exam. But for instance, I don't check prostates. And so I'm like, go to your primary care every year, do your annual physical, get your prostate checked, or do your pap smear with your OBGYN, make sure you're up to date with that. And then I'll definitely remind people, okay, when was your last mammogram? Did you do an ultrasound with that? So we're kind of staying up to date with the screenings as well. So that's kind of how I view primary care, where you're seeing them mostly once a year, general screenings they're keeping you up to date with. And so I'm doing pieces of it, but people don't have to guess. I'm going to tell you, hey, did you do this? Making sure people have done all of the things that we have for screening that are available for them. But people have more access to me than their traditional primary care. So they can, at my highest level, they have text access to me where they can just message me. And I've had people message me in the grocery store, hey, which granola should I buy? Like, that can be a question, or it can be a little bit of a bigger question that happens. And then I have portal access as well. But this is for continuation of quick care between appointments, where it's okay, depending on where we are in your care, I may be seeing you once a month, which is obviously way more than you would see your primary care unless something's actually wrong. Because we are wanting to get these screening tests done for prevention reasons. We're not waiting. So I think how many times you see me is going to be way different. The access level you have to me is going to be much different than a primary care setting. Yeah, I hope that somewhat answers the question.
No, that I think that context is really helpful. So for you do tell people to keep their primary care doc for those kinds of things, and then this is a much more personal, high touch, and they have access as they need it. And then the additional testing for primarily preventative purposes. I want to talk about the tests that you use that you think are really useful, and then maybe some of the ones that you think are not particularly useful. So let's start with the former first. What do you like? What are the tests that everybody gets? What are tests that some people get that you think are valuable? And how do you decide on that? And I guess one question, again, I don't want to get too much in the weeds, but do you work from a model where you have a sort of basic set of tests that are included, and then people will get referred for additional tests as needed?
Yeah, good question. I have 3 tiers that you can work with me on at this point. So I've gone through many iterations of how I work with people. And my lowest tier, nothing is really included except for the visits with me. And then the highest tier one, everything is included. In the middle, somewhere in between. But regardless of what tier you work with me, you have access to all of them. So you may be paying out of pocket for all of them here and there. You're like, I can't do that one, but I'll do this one, kind of thing. So I have a lot of flexibility there. And in terms of, everybody's going to get a comprehensive blood work panel. So that's like set in no matter what, whether we go through insurance or, you're in the tier that it's fully covered and it's out of pocket, then that.
And I don't want to get into all the blood tests, but in a general sense, like what do you think is important when you say comprehensive blood tests?
Yeah. So you're going to do everything that your primary care would do. So like
Sure.
CBC, like I'm not going to list all of those, but like just standard blood work, of course, is going to be included. In terms of additional things to that, we're looking at advanced cardiac markers, apolipoprotein B, LP(a). We're running once at least in everybody. And then we're doing things like vitamin D, which should be standard of care. Some primaries it is, some primaries it's not. Hormone levels, depending on where you're at in age, maybe. That's a maybe one. Testosterone for sure in men. And then what else? Big ones that I'm looking at. There's a million. Inflammatory markers, micronutrient levels that are available and actually useful. Things like homocysteine, which is kind of an inflammatory marker, also like a B vitamin marker as well.
Do you typically look at metals and toxins? Is that part of your standard, or is that something you...
Yeah, great question. So I'll look at lead and mercury in the blood. Those are pretty good markers that we have available, but we're not doing urine heavy metal screening. So we can talk about that when we talk about like these functional medicine labs.
Sure.
That's one of those that maybe has potential, but the current iteration of it in my mind is not. It's not useful.
Okay, so let's come back to that because I want to get to the tests that you think are not useful, but let's talk about the ones you think are useful first.
Yeah.
Okay, so comprehensive blood work.
Blood work, DEXA scans on majority of people, not everybody, because there's some body dysmorphia that may make it so it's not going to be a good option.
Okay.
So, but majority of people will get a body composition test to look at visceral fat, lean body mass. I know you guys do that as well. VO2 max test on everybody that I can convince to do it. There's a couple exceptions.
And when you say convince, it's because the VO2 max test takes a lot of exertion. It's kind of hard. And there are probably some people who it's not a great option for as well.
Some people just can't do it. It's not a safe option.
Right.
And then there's some people that are just like, I have to do what? I remember when I was in my undergraduate, I was in the exercise science department doing my undergrad thesis, and I did VO2 max tests. I was doing a sub-max protocol. But anyways, I have to pay my friends to do the VO2 max test. And now people are paying me to do VO2 max. So like there's been such a shift in, you just like, but it's great. So we do that on pretty much everybody as well. Advanced cancer screening too. So first of all, just making sure people have gotten their mammograms, maybe breast ultrasound as well.
What everybody should be doing. Yeah.
But especially in the integrative space, sometimes I'm really pushing people to do those things. Whether it's, what else could happen to me, or I don't know where some of this information is coming from, but sometimes...
You mean there might be risks associated with overdiagnosis or with the test itself? Is that the...
No, it's just this pushback, I think, towards conventional medicine in general, or this distrust that it's developed. And colonoscopy is one of the most useful screening tools we have. So I'm just making sure people are up to date and doing those as early as possible. Yeah. So, the date used to be 50 years old. Now we can do them at 45. And then there's indications earlier too. So if I have somebody at 35 with constipation, I'm like pushing them.
Yeah. And I want to just make sure I understand you correctly. Anybody could do it. You might have to pay out of pocket, but the insurance will cover it now at those ages. Yeah. I was bad, and I'm going to do an episode on this. So I won't give the whole story away. I actually just had my first colonoscopy. Should have had it at least 3-4 years ago, but totally glad I did. So I had 3 polyps. They got rid of them, but now I'm on the 2-year plan. Okay. So I have to go back every 2 years.
Yeah,
but yes, it should be done.
It should be done. Yes, so making sure there. But then we have the advanced cancer screening, which you guys talked about.
And do you mean gallery, or do you use another test?
So there's the MRIs, right? And then so Prenuvo, and I'll have patients that will do that. They're a higher price point, so you're talking thousands of dollars there, versus Gallery Grail, which is going to be a blood test that's going to be screening for about 50 types of cancers. Right. And we're not looking at cancers that are easily detectable through colonoscopy mammogram. Right. So these are things that we just don't have a good screening test for. So we're doing mostly that one. And then some people will want to do the Prenuvo either in addition or instead of.
Got it.
Yeah. You guys do the blood test at Optispan?
We do Gallery on everyone. in the concierge program.
Mm-hmm.
And then for people who want whole body MRI, we're actually going to move towards doing whole body MRI.
Mm-hmm.
Again, not going to force it on people, but probably for everyone. And again, I had an episode, I did my whole body MRI, I don't know, probably 4 or 5 months ago now. I wasn't a big believer that in how powerful it is. But now I'm more bullish. It was, people can watch the episode.
Yeah,
like,
perfect.
I think the process and the information you get back. So I guess the way I would frame it is, unfortunately, I think the companies that are doing these sort of direct to consumer whole body MRIs give you information back and say, take it to your primary care doc. And the primary care doc isn't going to know what to do with that. I think they need a doc like you that can then help them interpret the MRI and take action if necessary. So I think it's a very powerful tool. I think often the tool is not used in a way that is helpful for many people who are getting these whole body MRIs.
Yeah. So I used a company in LA that does the analysis for you. So they take out some of that. And mine personally, which I think is going to be the most common, it's kind of what I like almost hype people up with before, is it's very likely you're going to come back with something.
Oh, yeah.
Right?
Yeah.
So these incidental findings are, depending on what age you are, like almost guaranteed in most people. And so there's a group of people that have really high anxiety levels. And those are where we're telling, okay, is there going to be more benefit or harm here? Because me personally, I had a cyst, I think ovarian cyst or something, and I have to monitor it once a year with an ultrasound now. You know, am I still glad that I did it? And like, I know what that means and I don't care. So I can kind of just not think about it. But there's those people that are like, okay, that could spin them into a spiral.
Yeah, no, I totally agree. And I think that's really important, that like everything else, there's a component of knowing your patient and knowing which tests are going to be best for them. And I think this overdiagnosis, this is sort of what I was alluding to before, is a real thing. And again, some of the tests, that's less of an issue, but whole body MRI is a place where, yeah, you're right. You're going to find stuff. In many cases, it's going to be, totally normal aging, right? Not pathologic in any way, but can create anxiety or can create follow-on testing, which is more invasive in some cases. So yeah, those are things you certainly need to be aware of.
Yeah, those are the downsides right now, and they'll get better. We do advanced cardiac screening, so heart imaging, mostly clearly, but we're looking at CT angiograms with AI.
And do you recommend that for everyone or only for people who have cardiovascular risk factors?
Individual, but majority of people. Yeah. I'm smaller than you guys are. I'm getting the sense where it's like I'm seeing each person, so I'm deciding in real time. And for most people, I'm recommending it. There is the potential, similar to the whole body MRI, where we could have a finding that does not indicate we should be in the cath lab or anything like that, but can create some mental stress for somebody to know.
Absolutely.
So that's a consideration as well.
Yeah. I think that's really important, and I don't want to diminish it because it's something that as we start to talk about all these tests, you can forget that, yeah, for some people it creates a lot of anxiety, and that's counterproductive. That's not what we're after. So figuring out, and this is sort of a personal thing for people, probably a lot of the people who are listening have the means to go out and get these tests themselves, or they have a doc who will work with them. But knowing yourself and knowing kind of where you fall is really important.
Super important.
So I've learned, I kind of like to have the information and it doesn't stress me out. I haven't done the Clearly yet, but that's on my list, and I'll do an episode on that when I do it. But I think that's something to certainly think about.
Yeah, because I think one of the things we have to be thinking about, like as we've talked about, like what should we include in these models and what shouldn't we include in these models is the outcome of this test going to change our clinical decision making?
Right.
And the answer to that in these circumstances is not always yes. Like if somebody has an elevated level of ApoB and we do it clearly on them and it shows, X amount of plaque formation, is it going to change my clinical decision? Well, maybe if we're like, wow, you have almost a complete occlusion, like you got to go to a cardiologist, we got to figure this out.
Yeah.
But a lot of the times it's going to be like, no, we just got to lower your ApoB, and we knew that beforehand too. So
yeah, but I agree with you. And I would say it may change how aggressive you are or how aggressive they are
or willing
at addressing that. Yeah, exactly. Right. So I'm sure you experience this. Some people come in and they're very resistant to taking a medication. They're like, I want to do everything through lifestyle. But if you find that okay, this is pretty bad, that can tip them into being like, okay, we need to take care of this now.
Yeah.
So I think there is a
Yeah.
place for that as well.
And that utility can be really helpful for people, just to
Right.
have bigger numbers and say, okay, I'm really into this now.
Right. Right. So now I'm not an MD, obviously. So let me make sure I get this right, and so that the people listening can understand. So Clearly, I understand that will detect both the hard plaques and the soft plaques. Can you talk about that and why that's important?
Yeah, and taking one step back, we have something called the coronary artery calcium score test, which is a
Right.
CT as well. And that one has been used for a really long time to identify calcified plaque in the heart arteries. And I still use that one because there's some people that, finances are an issue and it's a much cheaper
How
test.
much what's the relative cost there,
It
ballpark?
depends. It depends
Yeah,
if you're getting insurance involved and all this
okay.
stuff. But you're looking at like 300-ish for the coronary artery calcium score test. And if you're out of pocket for the CT angiogram, you're around the 1,800 mark. You can kind of use insurance and get it down to 800-ish sometimes. But again,
Okay.
a lot of nuance there. But it's more expensive, bottom line. And so the calcium score test, you're just going to see calcified plaque. And if you look at, you can Google right now, like disease progression of atherosclerosis, the stages, the calcified plaque, you're looking closer to the end stage of disease. It's what happens at the very end. But in the beginning stages, you've got foam cells and you have this then soft plaque that forms, and you wouldn't see any of that on the coronary artery calcium score test. And it is so common for people to come into my office and let's just say like their LDL is 140, which is high. And they'll go, but my coronary artery calcium score test, just a year ago was 0. And I go, okay, great. Love that it was 0. Still going to recommend the exact same thing because we don't know based on that test if you have plaque that's in formation, potentially more unstable plaque as well, that is just going to be calcified in a few years. So we're always looking at prevention. It's like, it's great that we don't see any right now, but it doesn't mean you don't have it in progress. And it definitely doesn't mean you're not going to have it later. Because if you're a 30-year-old woman with a 0 calcium score, it tells me nothing. I would not expect calcium in that or calcified plaque in that person. So yeah, so that's the benefit of a Clearly is we can start to see earlier stages of that soft plaque formation.
And what do you, well, maybe you'll tell me you never see this, but what do you think about people whose lipids look terrible, but they're clean on a Clearly?
Yeah, and you do see it. You do see it. So there's other factors that are going on, and I don't think that we fully know, but I still treat that person.
Okay.
So it depends on what I will say. I actually had the Clearly founder on my podcast, and so we talked a little bit about this. If you come to me at the age of 85 and you've had lipids like LDL, ApoB high, like 150 or higher, like your whole life, and your Clearly is 0, I feel way better about not doing anything about you because you've gone 80 years and something else is going on here, right? Where you've got like all the genetics that are in one direction. Versus if you're a 30, 35-year-old woman, you come to me with a Clearly that's clean and you have high LDL, doesn't change my decision at all. I'm going to say, do you want to roll that dice and hope you're that 80-year-old woman that is the minority? Or are you willing to do something in terms of very little risk, potential huge, we're talking life-saving benefits?
And what's your typical strategy in that case for that woman?
Yeah, it depends where she's starting. So if she comes to me and she's on a keto diet, she's eating a ton of saturated fat. If she's at the 150 mark, I'm probably going to tell her to go on meds no matter what. But we're going to do all of it. So we're going to make sure you're exercising. We're going to reduce saturated fat in the diet. We're going to increase fiber in the diet. And then most likely pharmacology as well. There's most people that come to see me are eating either relatively healthy or very healthy.
Yeah.
And so we're looking at a genetic component, and people will often see and be like, oh, how do I have high LDL? Like I'm doing everything right. Like what am I doing wrong? And they'll put the blame on themselves. I'm like, the genetics, you're just like, you got the wrong genetic profile, and it's so common. So I try to, and I'm interested to see what you say about this because I know probably linguistically it's not correct, but I try to phrase it to them more so as like, you're taking a longevity medication for you right now. Because this thing is you're not necessarily treating a disease yet because we don't have a disease in process, but you're preventing potentially a disease from forming. And so people don't want to say that they're sick. And I'm like, you're not sick. can we think about, is this a longevity drug for you? And once you switch that mindset, people are like, oh, yeah, I like it now.
If that works, I won't criticize the longevity piece. Actually, just so that people are clear why, what we're even talking about. I think when I think longevity, I'm like, does it target the biology of aging?
Yeah.
You're thinking like, will it, keep this person from dying from heart disease in 10 years or 20 years or whatever. So totally get it. Okay. You mentioned genetics. So do you do genetic screening in your practice?
Tiny bit, not a ton. And I would love to know what you guys do at Optispan. Because I think that's like a whole sector that is really interesting to me. And I'm not a geneticist, and it's a huge topic, right? So like you need to understand it more than I do. I do like ApoE testing on my patients. I do specific things with my patients and interested in it. And then also like I've seen, because I've done some on myself with some of these eclectic lab companies. Yeah. And a lot of it is like, this could happen, but why wouldn't I just check the endpoint?
Right.
Versus the potential? Because clearly it's not being, like I had like an obesity gene. I'm like, okay, but that's not happening for me. So
yeah,
that's
no, I think you're right in the sense that if you have biomarkers for everything that are more proximal to tell you exactly where you're at and whether you're on the path to disease or pre-disease, that's certainly more informative than looking at your risk, right? Yeah. I think the way I think about genetics, and again, it's an evolving space, right? We're constantly learning more about individual gene variants that can cause disease. Those are usually severe variants, meaning if you have that allele, you're likely to get that. Or like ApoE4, we mentioned, can increase your risk by 5 to 15-fold for dementia and heart disease. But then there's these polygenic risk scores where you look at many, many different genes, and that gives you sort of a sum risk for certain things. Now, you can do these polygenic risk analyses and get sort of ridiculous things like, I've shared this before, so I'll share it again. This one company we worked with likes to tell polygenic risk scores, and then they give you a smiley face or a frowny face.
Oh, I don't like it.
Yeah, well, and when I opened mine up, fortunately, my genes are kind of like very vanilla. I don't have a lot of bad stuff I don't have a lot of good stuff, not a lot of bad stuff, but one thing that was at the top of the list was this frowny face for flatulence. So you can do a polygenic risk score on flatulence. And I'm like, if you ask my wife, she'd probably agree with that, but that's not particularly relevant.
It's a great example of like completely useless, right? Like I can tell you if I'm farting or not.
Right, exactly. And other people can probably tell as well. Yes. Yeah. So anyways, I think you have to be careful a little bit with genetics for partly because of what we talked about before. Some people can become very anxious about the information that they get from their genetics. But my view is I think it helps give a more rounded picture and can also kind of just tip maybe the treatment plan in some cases to make it more aggressive. If you see somebody's got biomarkers that are trending a certain direction and you see they've got a strong genetic or polygenic risk component, that may tilt you towards being a little bit more aggressive in the way you try to prevent progression of the condition. But it's very rare, I think, that you're going to get a clear, this variant is with 90% likelihood going to cause this, so we need to do X now.
We're not looking at deterministic genes more so than,
And everything's genetics by environment, this, but for most things, environment is going to be more predominant than genetics, which comes back to lifestyle and all the stuff that I think we both agree is where we usually want to start. What about, do you do anything with ultrasound?
Minimal. So I'll have, every single woman do breast ultrasound. But we're not doing, I think you guys are doing more like general screening.
Yeah, very, very, it's just a screening tool, but looking at, like fatty liver, carotid.
So I should say, I am working out of a model where I go to people's houses. I do have an in-person office, but I'm sending out for labs. So like I did a liver ultrasound yesterday on a guy, but I'm sending him to a local lab because he's in
refer
California.
For screening or diagnostic.
Of course, I'm doing it when liver enzymes come back high, but in terms of, am I doing it on somebody who's asymptomatic? Not right now.
So I don't want to spend a lot of time on it, but it's worth maybe just talking about, like, I think most people can probably guess what the things are that you see most commonly, but like what are the conditions? And I know your clientele is probably relatively healthy, but what are the conditions that are, really, really common out there right now in the general public that people should be thinking about?
Fatty liver is one of them.
Yeah.
So fatty liver is extremely common. And with that will come this whole category of just like metabolic diseases, right?
Right.
So it's very common to see fatty liver if somebody's pre-diabetic, diabetic, has insulin resistance. So we're looking at all of those, and we're looking at it with a little bit finer tooth comb too. So instead of just doing a A1C on somebody, which is a useful test, and we do run it, we're also going to do an oral glucose tolerance test.
So do you do that for everyone, the full OGTT?
Yeah.
And that
so it
measures
takes-
both glucose and insulin over
do both.
time with a set amount of glucose delivered.
Yeah, 2-hour period, and you're going to give them a set amount of glucose and see how they respond to that.
Okay, I'm going to see how you react to this, just because you can tell me that it's completely dumb. But would do you think you could do the same thing with the CGM just by eating jelly beans?
Kind of, yeah, kind of. And sometimes my one thing that I like to do is throw a CGM on somebody and send them to the lab to do the oral glucose tolerance test.
Right.
Because then you can't get the insulin.
Right. That's the piece you miss. Yeah.
And the insulin can be really insightful in some people. But yeah, there's a proxy for that for sure. I just don't know why I would do it when I could send somebody and do the exact test.
Other than some people might not want to go into a lab and drink Glucola, right?
Right. Totally. But yeah, that's an example where we want to look a few stages before.
And you do that because you can both see the glucose response, but then the insulin will tell you about insulin sensitivity, insulin resistance, which is, probably one of the most important markers. I would think, and I'm interested to know if you feel differently, but one of the most important markers when it comes to, if you had to measure one thing, to metabolic health.
Totally. It's going to give you a ton of insight, and it'll give you more than just a fasting insulin level in my mind, because you're actually doing a functional test.
Right.
So what happens when you consume X amount of sugar, and how does your body respond to it? That being said, I'll use a glucose monitor on most people once. Again, there's people that I will not put a glucose monitor on as well. So I've screened for
And is that because it'll cause them anxiety and
disordered eating patterns? If they come to me and they're on an ultra restricted diet already, like that's a sign where I'm like, this could do more harm than good. A lot of people, I'm almost showing to them that their body's more resilient than they think. And that's because of the sector that the people that I see. So these people are healthy people already. And some of them have gone down these crazy rabbit holes on social media, and they've eliminated so many things in their diet. And I'm like, you can eat bread. Like we can think this can be part of a healthy diet.
Yeah.
And so sometimes I'm actually trying to reintroduce foods that way to say like, you're totally fine. Like we don't have to worry about this. So it just depends on where the person's at.
Yeah, it's kind of crazy what you can find on YouTube.
Anything.
So is there anything we haven't talked about that you just really want to get out there?
Oh man. We did the stool testing. That was a big one. No, this has been really, it's been great talking to you. You're such a wealth of knowledge. I just appreciate you coming on mine and having me on yours.
Thank you. Likewise. There's so much we didn't talk about. I guess the last question I'll ask you is, when you think about longevity for your clients, we've talked a lot about diet. And I know we can't do this topic justice, but kind of what are the other big buckets that you look at particularly for longevity, or maybe health optimization, health span optimization, be a better way to frame it. I'll let you use the words that you think are most appropriate.
Yeah. And I should say, we started this off talking about like, what testing do I do? We didn't even hit all of them. So if you're interested, modernmed.com, go to the longevity tab, and I kind of overview it there in more depth. But strength and mobility are a huge bucket that I focus on. And I think it was off camera, but I was telling you the conference we met at, like, nobody's doubting that, right? Like everybody who's credible is in the line of like more exercise. Most people need to move more, get stronger. And that's measurable. So we're doing strength assessments for all of our patients, baseline retesting, creating strength training.
Yeah, you
programs.
mentioned VO2 max, but I think it's really important to also say, strength and muscle function, muscle mass, sure, but muscle function is really important as well.
It's more important than the mass piece. Would you agree with that?
I would agree with that, yeah.
Yeah, so we want to see how strong are those muscles and how functional are they. So we're doing strength assessments, training programs to get people to where they ideally want to be, and the cardiorespiratory fitness testing in terms of VO2 max, but also like there's so many places you can go get your VO2 max and then you just have this number.
Right.
It's like, what are you going to do with it? Like,
Do
where are
you
we going to
train
go?
for VO2 max, or do you try to get people to train for VO2 max specifically?
Yeah. So I give all of my concierge patients a plan, and it's different for everybody because some people are like, I want to hike, or some people, they want to do dance. And so a lot of the time, some of it looks similar, but we're tailoring it to what the person will actually do.
Yeah. Super
and then
important.
we're setting a retest date of like, okay, you're going to come back. We're going to do this again and see where you're at. But I think those are really big buckets to focus on. We talked about nutrition. So that's like the exercise piece of things. Biochemical piece we discussed as well. What other big
Do you
things?
do anything for sleep?
Sleep is an interesting one. The sleep trackers in my mind aren't super convincing in terms of the efficacy. And I've seen people wear them, get obsessed, and it makes their sleep
there's again an
worse.
anxiety component for some people.
But I'm interested in it. I mean, we're talking about sleep with everybody. And fortunately or unfortunately, I had insomnia in one period. So I know way too much about sleep physiology. So I can help a lot of people get their sleep in line. And so if you're not sleeping or you're not sleeping enough, that's 100% what we're going to talk about. But in terms of tracking, I'm more using diaries compared to sleep trackers.
And I think these things are all tied together, right? If you're eating well and exercising regularly, there's a good chance your sleep is going to improve. If you're sleeping poorly, that can have impacts on your likelihood of eating well and exercising. So recognizing that they all, work in tandem when they're working well.
Absolutely.
Great. Okay. So this has been so much fun. Thank you so much. Really appreciate the opportunity to come down here and chat with you.